phase of our entire workshop. We are entering into arrhythmias. So as I told you, this is the chapter which has driven many people from medical college itself. So many people have become engineers, auditors and so on after going into the topics of arrhythmias. Really they are little complicated. So we try to make you understand the basis first and then go into individual arrhythmias. Before understanding arrhythmias, we must know, as I told you in many chapters, the only easiest thing about arrhythmia, is its definition. The definition of an arrhythmia, any rhythm other than normal sinus rhythm. That's all. Any rhythm other than normal sinus rhythm is an arrhythmia. But the problem is to understand the normal sinus rhythm. So that's why I told you, we also know a lot of abnormals, we do not know normals. Do you know what normal situs is called? We know situs dextrocardia, we know situs ambiguous. What is the normal situs is called? Situs solitus. Many of us do not know. Normal situs is called situs solitus. We know situs dextrocardia, ambiguous and so on. Many times we don't know what is normal situs. It is called situs solitus. Normal portion of viscera is called situs solitus. Similarly, we must first define normal sinus rhythm. Once you decide what is normal sinus rhythm, if the rhythm is not satisfying the criteria for this normal sinus rhythm, it becomes an arrhythmia. So when we say normal sinus rhythm, we mean the impulse is produced by the sinus node at an appropriate rate and it is traveling through the correct pathway, correct speed, and it is reaching the appropriate place, and that appropriate place is responding to this current normally. All confused? Right, this is what the normal sinus rhythm is. So normal sinus rhythm, the impulse is produced by the sinus node at correct rate, it traveling through the appropriate pathway, reaching the appropriate place, and that appropriate place is responding to this current correctly. That's what we meant normal sinus rhythm. So we have 6 criteria to diagnose a normal sinus rhythm. 6 criteria. So this is a very important slide to understand arrhythmias. There are 6 criteria to diagnose normal sinus rhythm. So the P wave has to be upright in L1. The P wave has to be upright in L1. So first thing you must see is the upright P wave in L1. The P wave inverted in AVR. So this is what many times we have told you, because when the sinus node is here and it is going to depolarize the atrium away from your lead AVR will have inverted P wave. Oh, sorry. Inverted AVR. Then the constant PP cycle. For example, you have to measure what is the interval, what are the squares in between 2 adjacent P waves. Let us imagine in lead 1, 2 adjacent P wave has got 4 big squares in between. Throughout the ECG, your PP interval should have only 4 squares. For example, you take the PP interval at V5, V6, it should be only 4 squares. Throughout the ECG, the PP interval should remain constant. Then PR interval should remain constant. For example, L1, you measure the PR interval as 0.20. Throughout that ECG, the PR interval has to be 0.20. Because your PP interval is constant, because your PR interval is constant, your RR interval is also going to be constant. So when you measure RR interval 4 squares, in everywhere the RR interval should be 4 squares. And the heart rate should be between 60 to 100 per minute. The heart rate should not be less than 60, more than 100. So 60 to 100 per minute, the sinus rhythm. Any rhythm which does not satisfy even one of this criteria, is an arrhythmia. One of these criteria is arrhythmia. So as I told you, arrhythmia is very simple definition. Any rhythm other than normal sinus rhythm. To say normal sinus rhythm, you have to satisfy all the 6 criteria, all the 6. Even one is abnormal, it is not normal sinus rhythm. So look at the ECG here. So when you see first PP interval is measured, you must see from this PP, from this P, what is the interval of this PP interval. How many big squares or small squares this PP interval has got. So throughout, for example, you see the PP interval in V5, V6, you should have the same distance or same squares of PP interval throughout the ECG. Then measure the PR interval. If it is 0.16, throughout the ECG it should be 0.16. PR interval constant, PP interval constant, RR interval is going to be the same constant. Then the P wave is upright in L1 and it is inverted in AVR. It's a very important sign. P wave upright in L1 and inverted in AVR. Heart rate between 60 to 100 per minute is the 6th normal sinus rhythm. So the arrhythmias are classified into very simple way: bradycardia, tachycardia. Any heart rate less than 60 is bradycardia. Any heart rate more than 100 is tachycardia. So basically bradyarrhythmia or a tachyarrhythmia. Both these arrhythmias can be regular or irregular. Both these arrhythmias can be regular or irregular. Brady, tachy, regular or irregular. The first important approach to an arrhythmia when you have an arrhythmia in emergency room is to see the hemodynamic profile. With a patient, any arrhythmia, you must always see the hemodynamics: pulse, blood pressure, peripheries and the mental status. Any arrhythmia with a hemodynamic compromise, low blood pressure, high tachycardia, thready pulse, cold extremities and mental confusion indicates hemodynamic compromise. So any arrhythmia with a hemodynamic compromise, the patient should be given immediately electrical treatment. If it is a bradycardia, pacemaker; if it is a tachycardia, either a cardioversion or a DC shock. Then only you start diagnosing arrhythmia. When the patient has got no blood pressure or pulse, we should not going into the detailed history of how his grandfather died, at what age he died and so on. So immediate treatment and diagnosis when the patient has got hemodynamic instability. Whereas the patient is coming, walking into your office with an arrhythmia, his pulse is okay, BP is okay, everything is fine. You take an ECG, try to diagnose an arrhythmia and treat. So hemodynamic compromise, treat and diagnose; hemodynamic stability, diagnose and treat. So this is your first approach in emergency room in an arrhythmia. So first we run, then we'll sleep after lunch. So first is tachyarrhythmias. So we'll run. Tachyarrhythmias, first we want to see what are premature beats are. So this is the initiation of tachyarrhythmia is premature beats. Premature beats are those beats or depolarizations which come before the next expected sinus beat, just like our premature delivery, isn't it? Premature delivery before the next expected date of delivery. So like that, a beat is coming before the next sexual sinus beat is a beat coming prematurely is a premature beat. They represent increased irritability of the heart and sometimes they need to be suppressed. Please see to that only in sometimes, not always. Sometimes they need to be suppressed. For example, look at this diagram. So his PP interval is 4 squares. That means you expect a next sinus impulse to come around the 4th square from this sinus impulse, isn't it? So the sinus P wave is 4 squares. Whereas here you see a beat which is coming, the next expected beat is supposed to come at 4 squares, whereas this fellow has come before that 4th square, before the next expected sinus beat. That's why it is called premature beat. So this is a premature beat because it comes before the next expected sinus beat. So once you decide it is a premature beat, then you decide from where it is coming from. You must coming from atrium, it may be coming from the junction, or it may be coming from the ventricle. So first, having decided there is a premature beat, because a beat has come before the next expected sinus. You have a regular PP cycle of 4 squares. Suddenly you find a beat which is coming in 3rd square, which is coming at 2nd square. That is a premature beat. Once you decide it's a premature beat, then you decide from where it is coming from. There are only 3 areas: atrium, junction or ventricle it can come from. So you can see that here. For example, the premature beat can come from the atrium, the premature beat can come from the junction, or the premature beat can come from the ventricle itself. So these are the 3 areas in which the the premature beat can come from. How to identify from where it is coming from? The first is to decide whether it is a supraventricular focus or infraventricular focus or ventricular focus. In a supraventricular focus, for example, if the premature beat is arising above the ventricle, either from the atrium or junction, let us imagine above the ventricle it is arising. That is why it is called supraventricular focus. Once it arises from these areas, subsequent conduction of these premature beats are going to be through what? Through the normal conduction system. Then what will be the QRS of these premature beats? Narrow. So whenever your premature beat has got narrow QRS, it means this beat is arising above the ventricle and traveling through the same pathway as the sinus beat, and it will have a similarity of the QRS like a sinus beat. So whenever your premature beat is narrow, it is arising from a supraventricular focus. Whereas a beat arising from here, a ventricular focus, has got no access to the conduction system, so it has to travel through the muscle to depolarize the other areas. Because it is traveling through the muscle, this beat will have what QRS? It will have a wide QRS. So whenever your ventricular premature beat has got a wide QRS, it may be arising from the ventricle. Whenever your premature beat has got narrow QRS, it is arising from a supraventricular focus. So the QRS duration is 0.08, 0.12 second. So why it's some color is changing? Lead cable. Yep. So look at this ECG here. So you can see it here. This is a regular rhythm. P wave, P wave, P wave. It is coming around 3 squares. PP cycle is 3 squares. And you can see this beat. This beat is coming in 1.5 squares, isn't it? That means it's a premature beat. Suddenly it is coming. Whereas see this beat. This beat is coming in 2 squares. Whereas basically it is coming around 3 squares. This fellow is coming in 2 squares. So you have one premature beat here and one premature beat here, isn't it? So there are two premature beats. You have a regular sinus beats like this, and you suddenly find one beat here, one beat here. So see this beat. This beat's QRS is similar to the sinus QRS, isn't it? It's a premature beat, but the QRS is similar to the sinus beat. What does it mean? Supraventricular. Once you decide supraventricular, you must know whether it is junction or the atrium, isn't it? Whether it is a junction or atrium. For example, if this supraventricular beat is arising from the atrium, this beat will depolarize the atrium, then it will travel through the normal pathway to the ventricles, isn't it? That means you will have atrial depolarization which is preceding the QRS, But this P wave is different from the sinus P wave, because sinus beat when depolarizes in a particular direction, if this ectopic focus has a different focus is going to depolarize the atrium, it is going to depolarize in a different direction. So this P wave, although it precedes the QRS, will have a different configuration when compared to the sinus P wave. So if a narrow QRS premature beat, when your narrow QRS premature beat is preceded by a P wave, and this P wave is different from the sinus P wave, you know what premature beat this is? Atrial premature beat, right? For example, this premature beat is arising from the junction. Junction is not going to depolarize the atrium. Junctional beat is going to come down to the ventricles like this. So this premature beat may not have a significant atrial depolarization wave. It will have only QRS, not preceded by the P wave. So if a narrow QRS premature beat is not preceded by an abnormal P wave, what premature beat this is? Junctional. So you can see that here, if your narrow QRS premature beat is preceded by a P wave which is different from the sinus P wave, it is atrial premature beat. That you can see it here nicely here. So regular sinus rhythm is going on. It's around 4 squares. Suddenly you find this beat. See, this beat is coming prematurely. Is it preceded by a P wave? Yes, that P wave is inverted. You can see in the normal P wave is like this. You see the P wave which is completely different from the sinus P wave. So what premature beat this is? Atrial premature beat. Whereas this narrow premature beat is not preceded by an abnormal P wave. It's a narrow premature beat, so it's a supraventricular premature beat, not preceded by abnormal P wave. It may be arising from junction, so it is a junction. So you can see it here nicely. So suddenly you find this beat. You can see that is a premature beat. It has got a similar configuration as a sinus beat. It is a narrow, so it is a supraventricular. Is it preceded by a P wave? No preceded. So what beat this is? This is a junctional premature beat. So first to see it is a premature beat. Second to see the duration. If the duration is normal and it is similar to sinus beat, it is supraventricular premature beat. Then whether there is a abnormal P wave is preceding this QRS. If there is an abnormal P wave, it is atrial premature beat. If the P wave is not there, it is junctional premature beat. So this is where how to decide whether it is atrial or junctional premature beat. So you can see the difference there. So once again, this is a narrow premature beat preceded by an abnormal P wave there. The P wave is completely different from the sinus P wave. So atrial premature beat. Whereas here, this premature beat is not preceded by the P wave. So this is a junctional premature beat. Is that clear? Right. Now, if this premature beat, which is coming before the next expected sinus beat, has got a white QRS, that means it is arising from the ventricle, because from the ventricle, it has to depolarize the other ventricle or the other area of the heart going through the muscle. It has got no access to the conduction system, so it is going to go slowly, so it will produce the widening of the QRS. So white QRS premature beats most often, not always, most often from the ventricle. We can see this here nicely. So once again, sinus beat. You see that here the sinus cycle is going on around 4 squares. The 3 squares you have a premature beat. What is this premature beat like? It is big, it is wide, and it is completely different from the basic sinus. Whereas the supraventricular beat looked similar, sinus QRS. Whereas here the QRS is completely different from the sinus. Look at V1. See this premature beat. See, this is a normal sinus beat. Look at this premature beat. This is completely white QRS premature beat. So it is arising from the ventricle. What other things the patient has got in this ECG? I told you, look other things. Today, in this ECG, only VPD. Nothing else you will see. Isn't it? So what other things the patient has got? Yes? Single sentence diagnosis. Q wave. Is there any infarction here? Is there infarction here? What phase of infarction the patient is in? Chronic. ST is settled, Q wave is there, fully evolved subacute phase. So it's in fully evolved subacute phase of inferior valve infarction. What else is there? B1. Is there a P wave in B1 is normal or abnormal? What abnormality is there? Left atrial abnormality. What does it indicate? What is the QRS in V5, V6? What is the QRS in V5, V6? 1, 2, 3, 40. What ventricular enlargement is there? LVH. Is there volume overload or pressure overload? Volume overload. In an inferior valve infarction, left atrial enlargement, volume overload left ventricle, what is your diagnosis? He has got significant mitral regurgitation. Isn't it? Inferior valve infarction, left atrial enlargement, LV volume overload. He has got significant, you need not see the patient. This fellow has got significant mitral regurgitation. So all these things are available to you in the ECG if you properly see. Keep on applying. So I should not start with asking this is ECG, electrocardiogram. After that what you see a P wave. So when you put the ECG, you may say, sir, this is a chronic fully evolved phase, acute phase, VPD is there, and patient has got left atrial enlargement, patient has got a left ventricular volume overload, all these things you know. But only thing is you must apply to each one of the ECGs everything. Everything you forget about the completely erase your previous chapter and only learn this previous chapter. When you go to the other chapter, you completely, just like we told you, this is a fully evolved subacute phase of infarction, Q wave is there, ST is settled, symmetrical T wave inversion is there. So just keep on seeing other things. Okay, junctional premature beat. Then we come to the concept of a compensatory pause. Compensatory pause is a pause which follows a premature beat. Compensatory pause is a pause which follows a premature beat. What happens is, when there is a premature beat, the sinus rhythm adjusts. Sinus rhythm is going on nicely. Suddenly one fellow has come. So what does the sinus rhythm do is, it adjusts itself. It gives a small gap, then starts going again. So it gives a pause. It compensates for the one bit has come. So it compensates for the pause and little give pause and then restart its own rhythm. So the pause which follows the premature beat is called compensatory pause. compensatory pause. So the compensatory pause is measured by taking the RR interval which includes the premature beats. RR interval which includes the premature beats. So that is the measurement of compensatory pause. So what you do is you must measure what is the RR interval which includes, for example, let us say in this ECG. In this ECG, I want to measure the compensatory pause. I measure from this R wave to this R wave because this RR interval includes my premature beats. So this pause, the pause which comes after this premature beat is called compensatory because there is a pause there, then the sinus rhythm restores. There is a pause there, then the sinus rhythm comes. So this is a compensatory pause. So there is a subtle difference between the compensatory pause of ventricular premature beats and supraventricular premature beats. In supraventricular premature beats, the compensatory pause is supposed to be incomplete. Incomplete. What do we mean by this is when you measure the RR interval which includes the premature beat, it is less than twice of the basic RR interval. For example, your basic RR interval is 4 squares. If you measure the RR interval which includes the premature beat and it is less than 8 squares, twice of the basic sinus cycle, it is called incomplete compensatory pause. Most of your supraventricular premature beats will have incomplete compensatory pause, meaning the RR interval which includes the premature beat will be less than twice of the basic interval. Whereas when the ventricular premature beats are there, the compensatory pause is supposed to be complete, by which we mean the RR interval which includes the premature beat is exactly twice of the basic RR interval. So your basic RR interval is 4 squares. If we measure the RR interval which includes the premature beat will be exactly 8. For example, in this ECG, for example, if you see that this RR interval which includes the premature beat will be exactly twice of this basic RR interval. So when it's exactly twice, we call them as complete. When it is less than twice, we call them as incomplete. Supraventricular premature beats are supposed to have incomplete compensatory pause and ventricular premature beats are supposed to have complete compensatory pause. So this is how we measure the compensatory pauses. Then having seen the 3 types of premature beats, now I am going to concentrate on ventricular premature beat. How to decide whether the ventricular premature beat is malignant and it is going to require treatment. For that you must carefully look at the contours and associated features of ventricular premature beat. Now this beat is what premature beat? Is there a premature beat there? Yes. What premature beat is there? Very good. I told you I am going to concentrate on ventricular premature beat. So next slide is going to be ventricular premature beat only. So why it is ventricular premature beat? Wide. It is wide. So whenever the ventricular premature beat is very wide, for example, you can see here the ventricular premature beat is almost 0.2 seconds. It is so wide. Whenever the premature beat is very wide, it is malignant. Malignant means it may predispose a patient to ventricular tachycardia or ventricular fibrillation or sudden death. That's what I mean by malignant, right? So it is malignant. So very broad premature beats, more than 0.16 seconds is going to be a malignant premature beat. So width of the QRS is the first one. So QRS is very wide, it is likely to be wide. Whereas you can see this premature beat, this fellow is, you can see that nicely here. It is once again wide, it is different. It's a premature beat, all right. It is completely different from the sinus beat. It is tall, it is little wide, but you can see it's a tall and lean fellow. You can see that there is no notches there and the QRS complex is just wide. It is just small, just 3 squares, tall and lean. Whereas see this fellow, he is small and broad and multiple notches there, the peak multiple notches there. So that's why the short broad fellows are very dangerous. Tall lean fellows are very benign. I am telling you in the VPDs, not in human beings. So short broad fellows are in the VPDs, short and broad fellows with multiple notches are very dangerous VPDs. Whereas this type of tall lean fellows without any notches, good upstroke and clean downstroke, so this type of VPDs are likely to be benign. So the width, the notches and the amplitude of the QRS is very important to decide malignant versus benign. Then of course the frequency. When the VPDs are very frequent, you can see here alternate premature beats. One sinus beat, one premature beat. One sinus beat, one premature. What premature beat is this? ventricular premature beat. So alternate beats are premature beats. They are so it is coming very frequently. So this is called ventricular bigeminy. When alternate P waves, alternate ventricular premature beats are there with one sinus beat and sinus beat, it's called ventricular bigeminy. So when the ventricular premature beats are very frequent, especially when it is associated with acute coronary syndrome. For example, you are monitoring a patient in acute coronary syndrome in ICU. The monitor is working and you are seeing the monitor and you know some ECG. So the three prerequisites should be there. The monitor should be working and it's showing the correct ECG. You must be seeing that and you must be knowing something to interpret the ECG. When all these things are there, you must always see when the premature beats are coming, what is the number of premature beat per minute. So in acute coronary syndrome, if the premature beats are more than 6 to 7 per minute are coming like this in bigeminy, it is most often malignant. So very frequent premature beats are likely to be malignant. Whereas look these premature beats. So here there are two premature beats are coming in succession. Whereas here the premature beats are alternating with sinus beat. Whereas here the two premature beats are coming without intervening sinus beat. These are most dangerous VPDs called couplets. This is called couplet. So two successive premature beat without intervening sinus beat is called couplet. Whereas here when the VPDs are alternating with the sinus beat, they are called bigeminy. So that is the difference between bigeminy and a couplet. Couplet, there is no intervening sinus beat. Especially in acute coronary syndrome, this type of couplets is very, very dangerous. Thus immediately you must give lignocaine on seeing even one couplet, because immediately these are things which will predispose the patient to a ventricular fibrillation. So these are called warning arrhythmias. They warn you that the ventricular fibrillation is going to come, ventricular tachycardia is going to come. So that's why you have to detect them and immediately restore sinus rhythm by giving intravenous lignocaine or amiodarone. So you can see it here that these are couplet, but three ventricular premature beats are going to come in succession. It is called run. It's a run. It is much, much dangerous. Here three premature beats are coming without intervening sinus beat. Very rapid rate. You can see the rate there. The rate is almost 300 for this. At this point, for 3 beats, the ventricle is beating at 300 per minute. So rapid rate, 3 successive premature beat is called run. So bigeminy, couplet and runs are all very dangerous ventricular premature beats, especially in acute coronary syndrome. In addition to that, you can see that you must not only see for the ventricular premature beat, see what is happening to the basic ECG. What is happening to the basic ECG here? Is there anything there? Is there anything in the basic sinus beats? I don't want you to say ST depression. What injury? What injury this patient has got? ST depression is what injury? Say that. So from today everybody will say so that's what I told you, to intimidate others. When you see ST depression tomorrow, you don't say ST depression. Everybody will say ST depression. But you say subendocardial injury. Right? So when there is subendocardial injury, people are afraid. You say ST depression is asking. So this is a classical acute coronary syndrome. So these VPDs are happening during an acute episode. When the myocardium is ischemic or injured, these VPDs are coming, very dangerous, and they will immediately predispose to ventricular fibrillation. So all those, not only the VPDs, see basically what ECG changes are happening in basic sinus beats. And you can see this beat is so close to the sinus beat. You can see this beat is so close and it is falling on the descending limb of the T wave. The T wave has not finished, but the VPD has come. They are very close to each other. This is called R on T phenomenon. This is called R on T phenomenon. The R wave of the ventricular premature beat is falling on the T wave of the previous sinus beat. That's why they are called R on T phenomenon. So when the VPD is very close to the sinus beat, very, very close to the sinus beat, especially it is falling on the refractory period, relative refractory period, or the downslope of your T wave, it is very dangerous, and this is called R on T phenomenon. And especially in acute coronary syndrome, one single R on T phenomenon requires intravenous lignocaine or the antiarrhythmic therapy. So when they are very close to each other, the sinus beat and the premature beats are very close to each other, it is very dangerous for the patient. It is very dangerous for the patient. So we must be careful about R on T phenomenon. So you can see it here, here once again you can see that VPD is here. For example, it is a single lead. For example, it's lead 2. Let us imagine lead 2. All your premature beats are coming. 3 or 4 premature beats are there. But see the configuration. All these premature beats are having a similar configuration, isn't it? All these premature beats are having similar. What does it mean? This ventricular premature beat is arising from a single focus. So all your premature beat in a given single lead. You should not see in different leads. In a single given lead, for example, you see L2 or V1, all the premature beats are the same configuration. It is called unifocal VPDs because these VPDs are arising from a single focus. So this is once again, as we can see it here, we can see the L2 here. In L2, all your premature beats are there. It's a benign VPD or a malignant VPD here. It's likely to be benign. Why? Tall, lean fellow. You can see smooth surface, smooth downstroke, and no notches, tall VPDs. This is likely to be benign. And you can see here, this once again we are given a single lead, lead 2. See, one premature beat is here, another premature beat is here, and another premature beat is here. You have 3 premature beats in the same lead, 3 different configurations. What does it mean? Multifocal. 3 areas of your ventricle are irritable. Whereas when there is a unifocal, single area of your ventricle is irritable. So whenever you have a multifocal VPDs, it is dangerous. That means where multiple areas of the ventricle are irritable and they can predispose a patient to a dangerous ventricular arrhythmia. So this is the multifocal VPDs. Whereas here you can see the difference here. For a given single lead, you should not compare the VPD from L1 to AVR. AVR it will be different, L2 it will be different. You cannot say it's a multifocal. For a same lead, for example, it's L2, in that single lead, it should have the same configuration or it may have the different configuration. So this is a multiform VPDs. So this is what I told you. You can see it here, this VPDs. See, they are very small, having multiple notches. So very, very dangerous VPDs. For example, this is tall and lean, whereas here you can see multiple notches, very small amplitude. Very small amplitude with multiple notches VPDs are very, very dangerous. So they are malignant. So how you decide about malignant VPDs? When they are very frequent, more than 6 per minute, are ventricular bigeminy, very frequently coming, then they are malignant. R on T phenomenon, when the VPD, R wave of the VPD is falling on the T wave of the sinus beat, very close to the sinus beat, it is malignant. 2 successive VPDs are called couplets. 3 successive VPDs are called runs. Both are dangerous. Multiform, in a given single lead, VPD has got different configurations. It is multiform or multifocal VPDs. Short, broad with notches are very dangerous VPDs. And if the VPD is happening during either ST segment elevation or ST segment depression during an acute episode, if the VPDs are happening, especially when it is couplet and run, it is very dangerous. And if the VPDs are happening during a sinus tachycardia, normally the VPDs get suppressed when the sinus rhythm is beating faster. So in spite of sinus tachycardia is there, VPDs are manifesting means it is highly irritable focus which is able to overcome the sinus tachycardia and gets manifested. When there is an associated ECG signs of left ventricular dysfunction, that's what I told you, look at the LVH, look at the left atrial enlargement. The left atrial enlargement and LVH may tell you this patient may have additional left ventricular dysfunction. So VPD with LV dysfunction is quite dangerous. So when you give drugs like lignocaine and amiodarone, if the VPDs are not getting suppressed, that means it is a dangerous VPD. So not only diagnose a ventricular premature beat, look for these signs because these signs indicate the malignant VPDs. Why I am saying this is not all VPDs require treatment. Many times you do not give treatment for a VPD because as you can see, all VPDs do not require. Normal hearts can have VPDs because you cannot have in anybody absolutely regular rhythm. It is not possible. If the patient has got absolutely regular rhythm, he is not normal. It is absolutely normal regular rhythm. Whatever he does, the heart rate is 70, he is not normal. The heart rate has to change and you can have some premature beats and so on. Benign VPD in normal hearts may be left alone. So that's what is decided. So VPD has to be decided it's a benign, and you see structurally normal heart, you do an echo, there is no LV dysfunction, there is no valvular diseases, nothing, still the VPD is there, they are left alone. Many antiarrhythmic drugs are dangerous than arrhythmia themselves. That's why we don't treat. So many of your antiarrhythmic drugs are more dangerous than arrhythmia. You will create more problem. The VPD will be just coming and going. By giving amiodarone, you will produce thyroid function abnormality, you will bring lung fibrosis, you will give all sorts of skin manifestation by giving amiodarone. VPD will not do anything. It was coming, just coming and going. For that, if you give amiodarone, you will end up with a problem of more dangerous diseases. That's why many antiarrhythmic drugs are more dangerous than arrhythmia themselves. Arrhythmia should earn its treatment. You should not give the arrhythmia its treatment. The arrhythmia should say, hey, I am malignant, I am couplet, I am run, I am RNT, I am short and broad and having notches, you give me treatment. So you should not jump to give a treatment when you have a single lean tall VPD in a young lady with a mitral valve prolapse and say you have a VPD and give start and amiodarone. So you should not give treatment. The arrhythmia should earn its treatment by showing its malignancy, because it requires more courage for not treating an arrhythmia. It requires less courage to treat an arrhythmia. But when the patient has got a VPD and say I will not treat you, requires more courage than treating an arrhythmia by starting a drug for every arrhythmia you are seeing. That's why the importance of knowing the ECG changes of ventricular premature beat and what are the conditions in which it is likely to be malignant. So the VPD should be seen in the context of not only the VPD per se, but also the basic sinus beat, basic heart disease. So you have LV dysfunction, you have basic ECG change of left ventricular dysfunction or an acute coronary syndrome, then only you have the correct diagnosis and management. So that's about the VPDs and the premature beats. So the premature beats in nutshell, they come before the next expected sinus beat. Depending upon whether the premature beats QRS is narrow or wide, you decide upon supraventricular or ventricular premature beat. If that narrow ventricular premature beat is preceded by an abnormal P wave, it is atrial premature beat. If the narrow QRS premature beat is not preceded by abnormal P wave, it is a junctional premature beat. The atrial, ventricular and junctional premature beats are supposed to have incomplete compensatory pass, by which we mean the R wave, the RR interval which includes the premature beat will be less than twice of the basic sinus beat. Ventricular premature beats will have white QRS premature beats, and the white QRS premature beats will have a complete compensatory pass. The RR interval which includes the premature beat will be exactly twice of the basic sinus interval. Once you decide it is a ventricular premature beat, through variety of changes in the VPD, you decide whether it is malignant or benign. The benign VPDs are left alone, reassuring the patient and removing certain things which can precipitate VPDs like coffee, cigarettes and mental stress and so on, which eliminate the VPDs. And of course, if it is malignant, you give appropriate treatment.